Good evening, everyone. So, my topic is about Jaipur rehabilitation technology. So, I'm working in the department which Dr. Pramod Karan Sethi, who is known for design and development of Jaipur food, started in the private hospital after he retired from SMS. Dr. Suranjan sir has already explained his views about him, and I find myself lucky enough that my association with him was for nearly 15 years. So he not only developed Jaipur foot, he developed low weight thermoplastic orthosis also and completely substituted the conventional calipers. So I'll be speaking about that. This is our department in a trust based private hospital which is 500 bedded, largest in Rajasthan and recognized for postgraduate teaching and super specialty teaching also. So this is our lobby, patient's lobby. So I'll start with the very common problems which we face in our day-to-day work. So this CTEV, clubfoot or congenital talipes equinovarus, we usually prescribe foot abduction brace, and this is most of the time used after Ponseti casting when full correction is achieved. Ponseti brace or foot abduction brace is applied. So when it should be applied few hours after removal of cast, and foot abduction brace is well fitted, open-toed, high-top shoes attached in external rotation to a bar at the length equal to the shoulder width or the pelvic width. So in this brace, the ankle should be in dorsiflexion by bending the bar at 15 degree with the convexity distally directed. The involved extremity is kept at 60 to 70 degree external rotation and normal side is kept at 30 to 40 degree external rotation. When both sides are involved, both shoes or the foot are at the 60 to 70 degree external rotation. The most important thing about the brace is that the mother should be instructed how to use it, because this is the commonest reason of failure of the brace is that the parents are not knowing how to put it on. So mother is instructed to keep the brace for nearly 22 to 23 hours with 3 to 4 breaks in the entire day for 10 to 15 minutes. That is in the initial period up to 1 year of age. Then she has to be trained to put the brace on correctly. Both the heels should touch the base of the shoe. This is very essential. If the heel is raised above, then the child is likely to pull out the foot from the shoe, and the deformity is likely to recur. And the position of the heel should be checked periodically. Child should be allowed to kick freely. Sock should be used as it absorbs the perspiration and prevents abrasion of the skin. If the child pulls out the foot, an additional ankle strap can be added on both sides to ensure that heel properly remains seated at the bottom. This is really very, very important because it is not easy to train the mother to put the brace on correctly, and most of the recurrences are due to improper training of the mother. And after fitting the foot abduction brace for the first time, the mother should be advised to come for the first follow-up visit after 1 month. In case of any problem with the brace, child not accepting it or crying excessively, she should visit even before the 1 month. And aim is to provide mobile, plantigrade and painless foot. Second common condition we encounter is congenital dislocation of the hip, where we use pelvic harness. This was first described by Arnold Pelvic in 1944 and was published in 1957. There was a long gap in between. This is used in congenital dislocation, subluxation and dysplasias of hip, and also used in fracture shaft of the femur of the newborn. So it is effective before 1 year of age. You can see the diagram. It has a shoulder strap, chest strap, hip abduction strap and the hip flexion strap. The proximal part is to be fixed at the both shoulders of the supine child. The middle portion is fixed at the waist, and the distal portion is fixed is to keep the child thigh in flexed and abducted position of the desired angle. It consists of a chest strap with shoulder strap that crosses posteriorly to provide stability, leg stirrups that extends up the level of the fibular head, and all straps should be adjustable. You can see this anterior strap, posterior straps, and the chest strap. Two sets of the leg straps, anterior extending from the inner aspect of the upper end of stirrup to the chest strap, posterior extending from the outer end of the stirrup to the posteriorly crossing chest strap, and these straps crosses the knee joint as well as hip joints. And for maximum mechanical advantage, the anterior buckle attachment should be in the anterior axillary line, and it can be used to flex the hip. It should be tightened until the hip is 90 degree to 110 degree flexion. It prevents the hip from extending beyond this point. At the same time, permits the hip mobility. Posterior strap crosses behind the knee and hip joint. Tightening it prevents adduction of the hip. It should be tightened to keep the hip in 30 degree abduction. This arrangement of flexion and abduction of the hip permits hip mobility, which is essential for the treatment. X-ray should be done every 4 to 6 weeks to check position of the head in acetabulum. The success rate is 80 to 85%. The possible complications are avascular necrosis of the femoral head and femoral nerve palsy. When capital femoral epiphysis appears to be developing normally and clinical examination shows normal hip, the child may be weaned from the harness. Remodeling of the capsule and pulvinar at the acetabulum will keep the head of the femur inside the acetabulum. And this pulvinar is an accumulation of the fat and fibrous tissue in the space next to the medial wall of the acetabulum, which can keep the femoral head lateralized. Then next is the von Rosen splint for congenital dislocation of hip. It is plastic frame that can be easily shaped to conform the contours of the child body. We use aluminum sheet which is covered with Ethaflex padding. This is for supine position of the child. Proximal part of the shoulder, middle portion around the waist, distal part around the abducted and the flexed leg. Vest strap can be used to retain the brace in position. The other are Elfield splint and Freischka pillow splint. The increased incidence of neurological disorder, now there are other braces. Now the increased incidence of the neurological disorders after COVID-19 and increased road traffic accidents are increasing the number of patients reporting to us for orthotic facilities. And polio-free India, you all have heard about its eradication, but the existing cases keep on coming to us for renewal of the brace. So any condition which reduces muscle power partially or completely is included in this group. Paralytic poliomyelitis is still the commonest cause of leading to locomotor disability. Other causes are cerebral palsy, spina bifida, meningocele, spinal cord injuries, head injuries, stroke, nervous system infections, neuropathies, congenital deformities, fractures with nerve injuries, delayed and non-union of fractures, failed total hip and total knee replacements. To restore ambulation, different devices are used ranging from simple walking stick to long calipers. Now, a few words about conventional calipers. You all must have seen this, must have used this. Still, these are used in most of the institutions. So they have very high rejection rate because they are heavy, made up of wood and metal. Second, swing phase knee flexion is not allowed in these braces, which makes the gait laborious and increases energy consumption to a significant extent. And third is much more hip flexor power is needed to provide the necessary thrust to initiate the swing phase. And you have to raise your pelvis, raise the pelvis with hip abductors and trunk muscles. Ground clearance becomes more difficult as one is required to circumduct the limb. The presence of the metal sidebar abolishes the subtalar joint mechanism, which is required to adapt to slopes and uneven terrain. All joints in the orthosis are placed external to our body, so they have to be congruent with the axis of the movement of our natural joints. The externally imposed axis of movement increases external and internal incongruence. And the best part with this kind of braces is shoes can be changed, because the biggest reason of rejection in conventional orthosis was that one was forced to use the same shoes all along his life, and in this you can change the shoes. So all these reasons were enough for the patient to reject the appliance. Dr. Raj Arole from Jamkhede did a very scientific follow-up survey and found the rejection rate more than 90%. These conventional appliances were replaced by low-weight total contact polypropylene orthosis. Polypropylene was chosen because of the following properties. Fresh in these appliances we use fresh homopolymer polypropylene, not the recycled one, because the recycled one becomes weak and it can break at any time. So this polypropylene is cheap, flexible, available in milky white as well as in skin color, and easy to use material. It is available in open market, can tolerate repeated loading and is fatigue resistant. Small cracks can be welded easily, non-allergic to skin, pressure points can be eased off easily with the help of the heat gun, and it has a good shelf life. There are some drawbacks of polypropylene also. One is excessive sweating, and the other is it is not able to bond easily with adhesives or the other materials. If you want to make a sandwich material or a composite material, it is not easy with polypropylene. Now the prescription right is entirely different in this kind of appliances. So in conventional appliances, these were based on the muscle power chart provided by the physiotherapist, and these were not considering the existing gait pattern of the patients and were not meant to deal with the real life situation. Now our prescription for low weight thermoplastic appliances, extent and distribution of paralysis depends on that, presence and absence of deformity, existing gait of the patient, and the real life situation is considered. That is, the patient may present with wide spectrum of problems ranging from simple limping causing socially unacceptable gait to totally bedridden condition like complete paraplegia. The patient may come with the demand to get rid of the walking support, with problem of frequent falls and progressive reduction in walking distance and speed. Now there are some useful deformities and harmful deformities. You have to consider it before taking up surgery as well as deciding about the braces. The useful deformities are equinus, which helps you in stabilizing your knee joint. Mild genu recurvatum, it again helps you in stabilizing knee joint. Supratrochanteric tightness and the facial bends within the abductor musculature helps you in stabilizing pelvis. Then some harmful deformities, calcaneus is a horrible deformity because there is no special brace available for it. Fixed flexion deformity at the knee joint, genu valgum, genu varum, and flexion abduction contracture at the hip joint. Now different situation usually appears when you are practicing in OPD. One is the completely flared lower limb, maybe unilateral or bilateral, with good trunk balance and normal upper limbs. So in that case, you have to provide KAFO. In conventional settings, you used to provide HKAFO, but in this kind of braces, KAFO is enough to control the leg. So the polypropylene quadrilateral top, which is strong enough to support the body weight borne on the ischial sheet as it grips the soft tissue of the thigh well and is snugly fitted to the thigh, provides rotational control to the hip. With the help of the two side bars, drop lock knee is attached to it. This distally is attached to ankle foot orthosis with pretibial shell to stabilize ankle and ensure plantar grade foot. Although it behaves like a conventional caliper, but it has certain advantages over it. This is much lighter in weight. The ischial weight-bearing quadrilateral tops makes the pelvic belt with hip joint unnecessary, and the choice of the shoe is possible with this. In case of paraplegia, same appliance can be used with the help of bilateral axillary or elbow crutches with support or walker support, and with 4-point alternate gait or swing to or swing through gait. Now you must have heard about this stance control orthosis, which is designed similar to KFO with automatic opening of the knee and knee when swing phase knee flexion is needed, and gets locked during the stance phase when stability is needed. In this the gait pattern becomes much more natural and energy consumption is reduced, making the patient more comfortable and confident. But this is a very costly affair, not easily available here, and you cannot get it repaired easily. Then the one is reciprocating gait orthosis. It is an extension of KFO with public parts and up joints. Thoracic extension is added to prevent uncontrolled collapse of the hip. It combines flexion of the hip with obligatory extension of the opposite hip. Essentially, the flexion power of one hip is utilized to extend the contralateral hip with a specially arranged cable. This is reciprocating gait orthosis. Is any one of you has used it or making it in your department? Anyone? No one. So I also not used it. Then the situation 2. When hip is stable and quadriceps muscle is weak. The patient is ambulatory with hand on thigh gait, where body weight is utilized from above via the hand to press the knee back to prevent buckling. This is very awkward gait which immobilizes one upper limb and often leads to problem ranging from back pain to scoliosis. This is a very common situation in OPD. It was Saltiel who in 1969 was working in Israel, used floor reaction principle. So in floor reaction principle, you have to understand the relation of the weight line with the point of contact with the floor. So you can see the center of gravity, then the knee axis, and the point of contact with the floor. So weight line is an imaginary line joining the center of gravity to the point of contact to the foot with the ground and its relationship to the axis of the knee joint, which determines the stability of the knee. So at heel strike, the weight line passes behind the knee axis, and at this stage the quadriceps muscles has to contract eccentrically to prevent the knee from buckling. And during hand on thigh gait, the hand is used to press the knee back to prevent it from buckling. So the weight from higher up is used by the hand. So this is what which stabilizes the knee in hand on thigh gait. As the body moves forward in its progression, the center of gravity overlies the knee and weight line confers the alignment stability to the knee joint. Quadriceps now stops contracting, and the mid-stance, the quadriceps shows no activity in EMG. Now the other option to stabilize the knee is to achieve the alignment stability. That would be to arrange the initial forefoot contact with the ground, resulting in weight line passing in front of the knee axis. Now you can see the knee axis has moved forward because the weight line, the connection between the center of gravity and the forefoot contact is anterior to the knee axis. So this is the basic principle of flow reaction orthosis. So in flow reaction orthosis, The forefoot contact generates flow reaction, which through the lateral uprights reaches to knee crosspiece located in front of the patella, leading to force the knee posteriorly in extension, thereby prevent buckling. So FRO improves walking distance, it prevents falls and enhances quality of life. It has to be used with laced up shoes. Patient has to be trained for proper loading of the forefoot with heel of the ground trying to push the knee back. Opposite side of the shoe may require half-inch compensation to compensate for the equinus on the other side. The degree of equinus, after several trials, it has been concluded that the heel of the shoe should be half-inch above the ground level. To ensure this, while taking the negative mold, the heel should be kept about 1 inch away from the floor to allow for a normal heel height of a shoe. Tendo-Achilles lengthening should not be performed in such cases. The calcaneus foot has a tendency to descend down more. The degree of equinus in such patients has to be slightly more to ensure initial forefoot contact, or it is better not to prescribe FRO in calcaneus foot. So after making several changes in original design and analyzing user reaction, we could work out a design which was very well accepted by our patient. This is the flow reaction design we are using at SDM Hospital, Jaipur. Case selection for FRO: there should be no fixed deformity at the hip and knee, no genu valgum or verum, no calcaneus deformity, good power in hip extensors, hamstrings and plantar flexors increases the possibility of successful FRO, and bilateral FRO is not feasible. Then comes the rear entry flow reaction orthosis. A lot of has been discussed about crouch gait cerebral palsy in the previous sessions, so I'll just take it up on the orthotic part. So it is a device used in cerebral palsy patients with crouch gait. It prevents excessive dorsiflexion at the ankle. It is helpful in mild cases and to some extent in moderate cases. You can see it prevents, it covers the ankle anteriorly and prevents excessive dorsiflexion. Then modified Linhae's KFO. It is a very effective orthosis for genu recurvatum. The design has been arrived after trying several options and works well. Equinus at ankle should be avoided because it aggravates the genu recurvatum. This is Linhae's KFO. This is non-articulated. And the problem with this design is that the supracondylar projection, supracondylar part of the orthosis projects up when the patient is sitting. So patient has to wear very loose trousers. So the solution for this problem is that you can make it a articulated Linhae's KFO. Just fix drop lock knee joint, and when the patient is sitting, it will bend like with the knee bending. So while taking the mold, considerable pressure is applied over the calf region to deform the soft tissue over a wide zone and is shaped like an inverted triangle with its base proximally going up, high up to mid-popliteal crease. This leads to formation of gentle bulge in the orthosis to control a tilt of the tibia backwards by pressing firmly against the calf muscles. Then PTB orthosis, used as offloading and supporting device, fracture leg bones, ankle and foot bones, avascular necrosis of the talus, neuropathic ankle and foot for trophic ulcers with trophic ulcers, and any painful condition of the ankle and foot like degenerative arthritis. We have used this device very successfully in multiple conditions. This is PTB orthosis, which covers your leg completely. This is the anterior part, which we call as tongue. This is anterior part complete. This is back. Then ankle foot orthosis you all are familiar with for foot drop, used for prevention of foot deformities and arrest of further progression of deformity, prevention of equinus, varus, valgus and dragging of the foot. It improves proprioception and balance. The correct prescription will be AFO in neutral position with ankle and heel. It is kept open anteriorly to permit easy entry. Figure of 8 strap is used to keep the heel seated in place. Bony thin limbs, Ethaflex padding is used, and when it is associated with sensory loss, you have to use microcellular rubber, the same rubber which is used in leprosy. Then metatarsal bar for metatarsalgia, fracture of phalanges, MTP joint, Freiberg's disease, Morden's neuroma. So excessive pressure at metatarsal heads may be reduced with metatarsal bar placed proximal to the metatarsal heads to shift the load proximal to the side of pain. Then supramellular orthosis for ankle and foot deformities, which extends just above the proximal to the both malluli. Then UCBL foot support, University of California Biomechanical Laboratories. This is again the almost same with the SMO with below the malleolis. Both are mainly used for prevention and further progression of deformities. Useful in mild to moderate cases only. General instruction that cotton stockinette should be used. Train the patient with an attendant to don and doff the orthosis correctly. Heel should be seated in the bottom. Velcro strap should be tied. Shoes with the laces are used for the patient by the patient to allow proper walk, and gait training is specific to appliances. Then these are the general instruction. Allowed to walk, patient is first allowed to walk for 5 to 10 minutes, then check for the any pressure points. If there are any other pressure points, correct them and again ask him to walk. Then if it is okay, then give it to the patient. So the take-home message is the early intervention produces good results, extent of disability is reduced, quality of life improves significantly, socioeconomic burden is reduced, and self-esteem of the patient goes up. Now this, I'll show you a small video which will show you practically how these appliances are working. Please. So this is extension prosthesis for congenital absence of femur. This is again congenital absence of both the legs. The hand is also involved. Fitted with the prosthesis, Jaipur foot at our center. This is above knee prosthesis. Patient is walking with the knee bending. Look at the confidence. He is negotiating stairs. You allow him to wear trousers and shoes. It is not visible at all. Negotiating stairs without any external support, coming down. This bilateral below knee prosthesis, negotiating stairs with slight support with the railings. This is the girl with using below knee aluminium limb. This is a rapid fit limb which can be made in 1 hour time with a Jaipur foot attached to it and a suspension belt of leather. You can see this is aluminium. This is before the final finishing. After final finishing, it looks like a normal leg. This is again bilateral below knee amputation with Jaipur foot. Look at the confidence and the balance. Patient is walking. This is again a prosthesis, below knee prosthesis. Now you see this patient came from Lucknow with LGB syndrome, college going student. And when he reported to us, he was having muscle power 0/5 to 1/5 only. And he was provided with this orthosis, that is articulated Linnaeus type orthosis. And with this orthosis, he started walking. Now, after a period of 2 years, he has recovered well. And we have shifted him to AFO only. Look at the balance and the confidence. He is a community ambulator going college with this appliance. So this is bilateral articulated Linnaeus KFO. This is FRO, floor reaction orthosis. You can see on the right side, heel is off the ground when he is walking. Just off the ground, touching the forefoot to the ground first. With 5-degree knee flexion deformity. Thank you.
Thank you very much, sir. It was very enlightening. I want to know about idea of choosing plastic molded AFO and the conventional AFO in stroke patients, because we always end up in confusion like when to go for plastic molded, when to go for conventional AFO. So can you please help me?
See, for all practical purpose, the plastic AFOs are better because it is well fitted and it prevents the development of deformity as well as further progression of deformity because the limb is fixed in it. Second thing is you can use the shoes of your choice. In conventional AFO, a black shoe, it is fixed to a black shoe and it is visible from outside through side bars. So cosmetically it is not acceptable. And the gait is definitely better with plastic AFOs. Cosmetically better acceptable. It is lightweight. Plastic AFO is lightweight as compared to conventional AFOs. And it gives you better control.
Both for improvement of gait and structural tightness or contracture, both we can go for plastic molded
Yes,
AFO.
for
It will.
plastic AFO is better.
Okay. Thank you, sir.